India here with us. Now I'll pass the floor to our NPOs, Drashti and Ovia, to take it forward.
Good evening, everyone. And I welcome our esteemed speakers from Oregon, India, and our dearest VP, Dr. Parthu Saha, and beloved audience to the webinar. I'm Ovia TS, currently serving as one of the National Public Health Officer, along with Drashti Rati, and we are very delighted to have everyone present here on Zoom and YouTube live stream. Over
Hi,
to you, Drashti.
hi everyone. As my co-national officer mentioned, we are delighted to have you all here. And you may ask why this webinar, right? Why organ donation or transplant? So, according to the statistics, around 16,000 transplants are performed annually in India. To be precise, last year we had 18,910 transplants. Now you may ask, oh yeah, Drashti, this is a good number, right? Why do we need to talk about it? Honestly, globally, the average organ donation rate is 11 to 12 donors per million population, whereas in India, it is only 0.81 donor per million population. Over 3 lakh patients are in the waiting list in India for organ transplant. The supply of organ donors to the shortage or to the patient has not kept up. Approximately 20 individuals die daily due to shortage of organ transplants, a number which is alarmingly high, revealing gaps in the awareness system and also the social readiness to embrace organ donation. Over to you, Ufta.
Yes. We all aren't here to attend just another webinar, right? Just another webinar for CV building or to get certificate. We are here to gain knowledge, which is sometimes left undelivered in our medical lectures. We are here for the vast understanding on the topic of organ donation and transplant that our excellent speakers have to offer us. By bridging the knowledge gap and promoting organ donation, this webinar helps to create a healthcare environment where everyone is aware of the basics of transplant and organization. And before we dive right in, guys, this is a gentle reminder to fill the pre-1 form if you haven't filled already before 5:30 p.m. And without any further delay, I would love to pass the floor to Sunaina ma'am. Thank you.
Thank you, Ovia. Thank you very much. I'm Sunaina Singh, CEO of Organ India, and it's a pleasure to welcome you all to this very important seminar, Introduction to Organ Donation, organized by Organ India in collaboration with MSAI. And our deepest gratitude to the MSAI team, as well as to all the guest speakers who have taken out time from a much needed Sunday break to come here. So today we're going to gather and discuss how healthcare professionals like yourself can play a crucial role in advancing the organ donation and transplant movement in India. I'd like to introduce our first speaker now is Dr. Ashish Sharma, who wears many hats. He is the head of Department of Renal Transplant Surgery at PGIMER Chandigarh, founder secretary of the Indian Society for Transplant Surgeons, and managing trustee of the Organ Transplant Trust, PGIMER. His active involvement in establishing deceased donor organ donation at PGI Chandigarh, leading to nearly 600 deceased donor kidney transplant, in addition to 400 living donor kidney transplants that he has performed. He initiated the pancreas transplantation at PGI Chandigarh in 2014 and has performed almost 70 such or more such transplants with the leadership position in the country. He is a member of the National Advisory Committee for formulating guidelines on deceased donor transplantation and National Health Authority. His topic today is General Awareness on Organ and Tissue Donation, the Indian Model for Organ Donation and Transplant, including the role of NATO, ROTO, and SOTO. So welcome, Dr. Ashish Sharma.
Thank you, Sunaina. Thank you for the wonderful introduction. And thank you for inviting me to this talk. Is my screen visible?
Yes, sir.
Great. So, and I must commend the Medical Student Association of India for engaging us in this activity. I mean, so not only this is for the welfare of society, I mean, this is actually very important for the young medical professionals, in the sense that you hear that every year the medical seats are full, the fields are saturated, the metros are all full of all the different specialists. But there's one specialty in India where it is just beginning to start, right? So, and this is what I'm going to highlight in my slides as well. And I can foresee that many of you would be in this specialty in the coming years. I mean, we have to increase our transplant numbers. I mean, if we want to become a Viksit Bharat by 2047, we have to increase the disease donor activity by 100 times. So 100 times, where are the professionals? We need pathologists, anesthetists, surgeons, physicians to take care of these patient researchers. So it's an immense area. So I'll be touching upon, I mean, in the given time. So I'll probably discuss briefly about these things, may not everything, but some things. I don't know how many of you have recognized this picture. I think you are young people, so I'm not sure whether I'll be able to get the feedback or not. But this is a very interesting picture which came up in the social media a couple of years ago. Somebody's having a heart transplant. You can see the heart is there. It's working, flushing out blood, and then there's another kidney here, and the common link is this, right? So what has PIC to do with all this, right? So I'm sure many of you would know, but there would be a lot others who are actually not aware of this, that these were the first time that these animal kidneys were successfully transplanted in humans, and they worked for varying period of time. So this was a proof of concept, and now we have already we have 2 startups which are actually breeding such pigs, which means that if these startups survive and become, I mean, they're already successful in the short term, we are certainly looking for an exponential growth in kidney transplant, that the human body probably will become like a car, that if you've got a silencer problem with the silencer, go to the market, buy a silencer. If you have a problem with your engine, get your engine oil replaced or something like that. So we see on the shelf organs. So that's a golden opportunity in the era we are living now. So, but till the time this becomes commercially established, we still have to rely either on the human beings. So either during their life, they can donate some organs, or after their death. And death, we know that death can happen either when your brain stops working, which means that you cut off your, something like functionally you cut off your head. So if you have a neck which is given way and your head is detached from your body, your heart still continues to work, continues to pump blood to your organs, and they can still survive. So all your head injuries lead to brain death, and this is what we use an opportunity to use these situations to convince the donor families to donate the organs of their living ones. And then you can have a cardiac death, which we are all aware that you do all those CPRs and all. As an intern, you would have done it many times, and you're not able to resuscitate the patient and you declare death. So sometimes you can actually take organs from these patients. So as was pointed out earlier also, we've seen a very rapid growth in the last decade. So 10 years also data showing that number of transplants surging from 5,000 to 15,000. So that's a 3 times number. And last year was even greater, to about 18,000. So we are doing fairly well as far as the transplant activity is concerned, to the extent that we are now the third number of amongst the list of all nations across the globe. So we are at the number 3 position, which is actually enviable behind USA and China. So, but what we have to recognize is that the progress in transplant is not cannot be confirmed only by absolute numbers, that we may be doing 18,000 transplants, but it is based on your population. So these 18,000 transplants are for a population of 130 crore, 150 crore people, right? So all these rates are calculated in per million population. So for 10 lakh patients, how much people are donating in your community? So that is a bottom line, and that is what we talked. And if you see here, you can't even see in India. So it's a small, the font size is small, but this is where we lie, like at the very tail end of this chart. So that is what is worrying, that if we are talking in per million population, we're 0.8, right? So which means that there's a huge scope of improving these numbers. We already talked that 2 to 3 lakh patients need transplant every year, but we are only doing about 1,000 odd donations and after death. And there's some organs you can actually retrieve while the patient is alive. So I can donate my kidney. I've got 2 of them. I can donate my part of liver, so the liver regenerates, and I am okay, and the recipient is okay. But what do we do about the heart? What do we do about the lung, the pancreas? So we have all those organs cannot be given during life, and hence the donation after death becomes more relevant. And if you know that we talk about that so many people die every day waiting for an organ, and whereas one donor can save up to 8 lives. So you get a heart, 2 lungs, liver, which again you can split, pancreas, 2 kidneys and intestines. And this, it's not about only organs, but now the progress in transplant has even increased. So if you see this, the 20-year-old child who was doing her bachelor's in engineering in Chennai, driving a kinetic, which many of us do, and she just meets with an accident. Fortunately, she does not die, but unfortunately, she loses her both limbs. So what is the life left for an engineer without the upper limbs? So, I mean, she's struggling for her life, even for drinking. And then she undergoes, somebody says yes to donation after death. She undergoes a bilateral upper limb transplant, which was not there before. And this is happening very much in our own country. And now she's 10 years post this transplant, and she recently did her MB, and she's now become an ambassador for transplant. So that is the power of transplant. And see this is a face transplant where a lady bitten by her own pet dog, and see the face. I mean, she was hesitant to even go outside in the public, and then she receives a face from a deceased donor after death, and look at the face, I mean, which is as normal as any of us. And so that's a person, the center is born after a uterine transplant. So transplantation is not, I mean, this is 10 years old, the first child who was born after a uterine transplant. So transplant is not only about life. Now it is the quality enhancing procedure, which means that you can actually use any of the tissues as well to get your life better, which also means that you are expanding it more and more, and we need more professionals for the same. So coming back to our country, where we were number 3 as far as total transplants are concerned, and why we are at in the tail end as far as the disease donation is concerned, because most of the transplants happening in our country are from the living donors. So a big chunk of the pie is from the living donors. So even in living donors, it is not that as again as donation in part per million population, we still at somewhere around the middle of the graph. If you have all the nations lined up, so we are somewhere in the middle of theirs at about 6 million per 6 per million population. And if you compare it with the other countries, like the developed countries, where the rate of donations vary from 37 to about 10. So we still have to reach this, increase our living donations by 3 to 6 times to be the best in the world. But when you talk about the disease donations, we are at the fag end of the tail, and the increase we need is about 100 times the current numbers to match the developed nations, which again by that time would probably have gone even further ahead. So why is it so challenging to have a donation? I mean, you're dying, you're going to burn your body and organs. So why is it so difficult for us to do all this? Because it's a complex process. It's not that it's unlike when you have a problem with your kidney, you see one doctor and he decides and he can do all the surgery and you are fine afterwards. But here there's a very complex science and laws and behind this process. So the donation is governed by an hospital administrator. You need ICU in your hospitals. You need to have the government involvement. The police is concerned because many of these donations come from road traffic accident patients. You need to have their postmortems done, which are carried out by the forensic in collaboration with the police. So there is a legal involvement there. When the patient is admitted, he does not come. Nobody comes to the hospital for the purpose of organ donation. Everybody comes to save their life. And if you do not talk in the right way, nobody is going to give a consent to organ donation. And we'll hear from Navdeep later in the program today what is the role of transplant coordinators. You need an intensivist who will manage this patient while while we are trying to save. And then after, once we know that he's brain dead, then still we need to save their organs. And Dr. Kajal is again there today to talk about the role of intensivists to manage these patients. Of course, you need to have a public awareness, and most importantly, awareness of the treating physician. So if the treating physician is not aware, like today we are talking to you about this organ donation, when we were in our training in MBBS, nobody, I mean, India did not see any disease organ donation. Our law came in 1995. So before that, all the people who have been trained, they had no idea, no clue about what is happening. Even neurosurgeons and neurologists, they had never declared they've never seen any death being declared because of brain death, which is a central concept to organ donation. So that is why we have challenges in now training these people who are established leaders in their own field, and to teach a neurologist or neurosurgeons about brain and brain death. You can imagine that it actually hits their ego, and I mean it's difficult to train after a certain age. And then, of course, to do a transplant, you need a transplant surgeon, you need physicians, and the surgeons and physicians cannot do anything unless you have a match, right? A match means that you need to have a very high-end lab working 24/7 at the time of organ donation, because your time is always limited. After brain death, patient can have a cardiac arrest, and unless the blood is circulating, if the blood stops, then the organs go waste. So during that period, to match those patients with the potential recipients, it's a big challenge. So many people are involved, and that is how we are there where we are. So when we talk about challenges India face, so the first thing comes about that there is lack of awareness amongst the public about the organ donation. So of course, but if you see the centers which have who have done very well in the field of organ donation across the country, so it is more about the medical professionals. If you ask me, when we go and ask for patients who are brain dead, so 30% would just say yes once they realize that the situation is beyond any hope and cure. So 30% say, please, I mean, if you are able to save somebody's life, please proceed. Whereas 30% will deny, no, I don't want to donate. I will be born in the next birth without any organs, or something of that sort will come up. And there's a middle 40%, which your transplant coordinator and your counseling technique, which is again a very scientific process, which can help them to convince to reach at the right conclusion. But what worries us more is this lack of awareness amongst the medical professionals. And it's not only related to lack of awareness, but it is the additional amount of enormous work which has to be carried out. I mean, brain death certification by medical professionals is again adds to their existing work in the way that the law states that you have to examine a brain dead patient twice, right? So while you can declare a brain dead, the patient with a cardiac death, you can just go alone as an intern or as an MBBS doctor. You can go auscultate the heart or document an ECG which is showing no activity. It's very simple. You can declare death. But when it comes to brain death, the law has been made so stringent that you need 4 professionals: the treating doctor, the medical superintendent, and so on. You will be again knowing more details in the next talk with my colleague, Dr. Ravi. So that has become more complex, and that increases the workload of the professionals who are engaged in this process. So that's again a challenge. So we have our society is very diverse, like each part of the country is a very diverse state in its own, and there are ethical issues everywhere, right? So some of the Muslim families may not like to donate, that say that the religion doesn't allow it. The Hindus will say, no, there's a rebirth and I will be born without an organ. So you have to convince them to overcome these issues, because no religion as such is against donation. In fact, the donation is considered to be the most noble uh, practice which you can do during your life. And last is your education regarding the terminal part of your life, which is we call an end of life care. So that again is not being practiced in our country at all. And I'll probably talk about it in my next few slides. So we talked about this is that physicians actually face a lot of difficulties, and some of them are actually not, they are actually very valid points when they certify brain death. Like when you say death, you think that there's going to be no movement of your human body, but here we are talking of brain death. And if you start to test your spinal reflexes, which may still be present, because they got to be present, because we've only talking about brain death. The heart is still functioning, our organs are all okay, the spinal cord is okay. So you may elicit these reflexes. You may have the Babinski sign there, or you may have your brisk reflex movements which may be present, which leads to a lot of confusion amongst the family. Also, family will say, the moment is there, how can you say the patient is dead? So all these things cause the problem. So central part to brain death is that there is no circulation going to the brain. If you do the angiography, you try to put a contrast, you will see that there is a cutoff at the level of neck. And what happens in all sort of injury, there is inflammation, swelling. Swelling leads to edema. Skull is a closed cavity, unlike the external part of the head. If you have any injury, the soft tissue will expand. You will have a big hematoma or whatever on there. But if something happens inside the brain, that swelling will only lead to increase in intracranial pressure. The increased pressure leads to further ischemia, leading to more edema and more higher pressure. And once your ICP rises to more than your perfusion pressure, you are left with no blood supply, which we call as brain death. As I already said, that the physicians at the moment are not trained. Nobody is training them, and you may become a neurologist or a neurosurgeon, but you are not trained to certify. There's no certification program. There is no the education regarding this certification of brain death. So when they start this, the first few brain deaths, they find it very difficult to comprehend what is happening. And being a legal thing where you have to sign on each paper, and twice at the interval of 6 hours, becomes too much of work at that point of time. So the second part of your organ donations come from an end-of-life patient, right? So currently what is happening in our end-of-life patients is that we keep on waiting for the heart to arrest, right? I mean, many of you would have seen as an intern that you have a patient with florid sepsis, his blood pressure is going down, but you still keep on treating. Same, you have a patient who's say 96 years old, he comes with some surgery, so for surgical emergency, so either you operate and keep him there and you know that it's not going to make it, or you just say, you explain to the patient, send the patient home, but do not allow him to have the comfort care in the hospital to die. So these are the challenges. If you do not practice end of life care, you lose an opportunity to donate organs, because this is another form of death that you actually let the patient allow to die by providing them comfort care rather than trying to cure or treat them. So I'll probably again clarify in this part. So far, I mean, our country, organ donation is equal to brain death. So you donate only if you're brain dead. Whereas a lot of other countries have actually utilized the concept of end-of-life care, cardiac death, and utilization of organs after cardiac death also. And problem with this is that only 10% of all death happens with brain injury. So if you are not able to expand that concept of cardiac death and transplantation, you are limiting yourself to only 10% of death. And with recent advances, those brain deaths also are now shrinking in number, because the moment the patient with head injury comes to an hospital, his skull gets opened. So you decompress, the skull is not closed now. So you do not allow the pressures to rise here. But at the same time, the brain injury may be so devastating that the patient will not have any useful life afterwards. So that concept of somebody whose survivability for a useful life is not there is still not in practice in our country. And once you have such kind of patient, I'll just give an example that we had a patient who had road traffic accident. The skull is actually come out of the brain of the skull. So what do you do then? I mean, you can't put the brain back and hope that it's going to work. It's not going to do that. So this patient, he's not going to have a brain death because the skull is all open. So his pressures are never going to increase. What do you do him? I mean, most centers in our country will actually keep him into the ICU, will wait for his cardiac activity to stop. But whereas if this kind of patient comes to a Western setup, they will actually realize that there's no treatment and cure here. So you just need to provide a comfort care to this kind of patient, and not only to this kind of patient who's clearly brain dead, but to many other patients, for example, who are suffering from terminal illnesses like multiple sclerosis, Alzheimer's disease, many of the cancers, or other devastating brain injuries. So what you do there is that you actually take care of the symptoms only. If the patient has pain, you provide some morphine. You try to take care of all the symptoms rather than giving chemotherapy to a patient who's terminal. So you just give those. If he has some obstruction, you just give some nutrition to him. So all those are things. And during the same time, you initiate meaningful interaction with the patient during that period, or maybe even much earlier than that. Then what do you want to do after your life is going to be over? That okay, we know that we are facing this challenge. So do you want your organs to live after your death? If he says yes, then there's an option which is legally allowed in India, although the procedure is still quite complex, that you can actually withdraw life support and allow a peaceful death, or you can just continue with minimal support, provide sedation, comfort care, and let the person die. And if he has consented to organ donation, that gives you an opportunity to utilize these organs. So this is a graph I've taken from United Kingdom. So it's a small country. Population is probably a tenth of ours, or maybe less than that. And if you see, the green color is donations after from the living persons. So that's plateaued in 2009, and now actually it's probably showing a dip now. 2020 was the COVID year, but still the trend is downwards. But if you see these, the blue and the red are increasing, and the red is certainly increased a lot more as compared to blue. So the red line shows the donation after cardiac death, whereas blue shows the donations after brain death. It's not only true for United Kingdom, this is true for United States also, who does about 10,000 living donations every year, but 6,000 living donations every year. So that's static. Whereas the brain death, the blue and the red, after cardiac death, they are increasing, and there's a much valued spike in the terms of the cardiac deaths. Whereas our country, the Indian context, if you see, the only growth is there in the green bar, which is the living donor program, whereas the other ones, the red is practically non-existing, and the blue is now starting to show some uptrend. So the challenge with the living donor is that if you do not have a disease donor, I mean, kidneys are the most commonly used living donor transplant. So when the patient sees that someone in your family is struggling, so they come forward for donations. And with the kind of comorbidities existing in our population, it has now become very challenging to find a good donor, especially with the small families, and thereby putting unnecessary pressure on the parents or on the family members to donate their organs despite suffering from, say, hypertension or diabetes, which has become so common. But the pressure is so much that more and more people come forward, maybe mera kidney nikal do, I want my son to live, to the extent that, and these organs now are not the ideal organs, they are marginal organs, they will not even work to the fullest life as compared to a healthy organ. So, and many occasions now we started seeing that even people who have donated their kidneys have now come back with kidney failure after a few years, because originally this science was of donation from a living donation was meant only for very healthy individuals. So we are again compromising, and we need to stop this practice. But that can only happen once we increase our numbers. So this is a comparative chart where we have superimposed Indian data versus the data from the United States. So if you see the green bar, so we are actually way ahead in the green in living donations, more than what the US is doing. But when it comes to the brain death and the cardiac deaths, we are nowhere in the picture. So if we compare what is happening across the states, so India, I said, is not a single state. Each state of India is probably another country of its own. So 75 to 80% of donations actually is only being carried out to 6 states, what we have mentioned here. And when we talk of living donations, you see a stark comparison that Delhi NCR comes up suddenly is very high. So part of it is that a lot of international transplantation happen in the national capital, that a lot of overseas people come here to get with the living donors to get the living donor transplants. But again, so what I want to emphasize is that only a handful of states is doing the majority of work as far as transplant is concerned. So entire Northeast, many of the central states are actually and the northern states are actually do not have the capacity to do the transplant. So how will they encourage donations? And then we will be talking about in the next talk about the acts. So the Transplantation of Human Organ Act 1994 was the year when it was first passed and modified again in 2014 to ease the process of donations, which hasn't actually happened. So we are yet to see a certain bulge in the number of donations. It's a slow, gradual increase, which is much less as compared to what we need. So what can we do? So what can we do is that, obviously what we can do activities to increase awareness, not only amongst the public, but also amongst the medical professionals. And we can actually have identification of these donors in the ICUs. Providing ICU critical care to them is again important, that somebody who's got a devastating head injury comes to a busy hospital where you've got only one ICU bed and there are 6 people waiting. So it becomes very difficult to decide that who gets that bed. But if you do not give a bed to that ICU, the patient who's brain dead, you lose an opportunity to give benefit to many others for transplant. And then there's the role of NGO like Organ India, who can actually do these kind of meetings and talks to create more awareness. The government again has trying to implement various schemes. So we have a national body now, the National Organ and Tissue Transplant Organization, which has 5 regional organizations in each region: the North, South, West, East. Along with that, we've had now the laws. The government is trying to modify laws, but still there are discrepancies when you create laws and when you try to implement them. And modifying the law is again a very cumbersome process, has to go through both houses of parliament, makes your life more difficult. And now we have a national organ transplant program. So things are moving, but not at the way which we wanted. What can we do? We can actually emulate the copies of countries who are doing very well, right? So the same graph which I showed that. And this is what we have been able to do at PGI Chandigarh, that it used to be a dry state before 2005, in the sense that we used to have one odd donation in a year. And if you see that from that 0 to, we could actually take it to a high of 80 in 2017. So, and these are the things which we have done, and it's a very easily replicable model if we do the same thing at other centers. So some of things is that you probably have some meetings creating awareness, You have your leadership involved committed towards organ donation. You try to have patients being counseled by transplant coordinators who play a very valuable part in this process. And once you have established, you can actually keep on accepting so marginal kidneys, in the sense that marginal organs from death, diseased persons you can accept. And if you see that these are the policies, if you make, you see sudden jumps. So suddenly you see that from 1418 to C50, you make another policy change, you 80. So this kind of exponential growth is what we are looking forward. And this can only happen once you involve all those the key stakeholders. You have your protocols and all those things in place. So I think so it's going to be a challenge, and I like these words by Jeffrey Benjamin, that in each challenge is an opportunity, right? So you don't see as an obstacle, you see it as an opportunity. Like we could do it, and you name your bring a lot of fame to yourself if you are able to utilize in the way. So with that, I would like to end my talk, and I don't know whether we are going to take any questions here or not, but if you have, I'm most willing to answer them. Thank you very much.
Thank you, Dr. Sharma. So does anybody have any questions, or we can move on to the next talk?
Good evening, sir. Good evening, ma'am. I had one question. Hello.
Yes, please go ahead.
Sir did mention of xenotransplantation in the start of session. What are different factors that we consider which differ from human transplantation? Factors as in matching factors that we consider for organ transplantation. And how far are we from routinely performing such xenotransplants with high success rate?
So xeno is a lot of research has gone into it, that you actually humanize those organs, in the sense you do a lot of gene editing. So almost 10, now the current generation of those pigs is about 10 gene edited pig, right? So you keep on developing those generations, but we still yet to see any long-term success. So they still are going to do some clinical trials in the coming, say, 3 to 5 years. They probably will be do another follow-up, say another 5 to 10 years. So we still are about 10 years behind, if these are successful. So that if is always there.
Okay. Thank you, Dr. Sharma, for your wonderful talk. I can now introduce our next speaker, who is Dr. Ravi Mohanka. Dr. Mohanka is the Director, Hepatobiliary Surgery and Liver Transplantation at HN Reliance Hospital in Mumbai. His unit is one of the fastest growing programs with success rates of acute liver failure and liver transplant at par with the best in the world. Dr. Mohanka has trained and worked at some of the most reputed hospitals in India and the US, including the prestigious Thomas E. Starzl Transplantation Institute at the University of Pittsburgh. His areas of expertise and current practice include living donor and deceased donor liver transplantation, intestinal transplantation, pancreas transplantation, and hepatobiliary surgeries in adults and children. He has undergone advanced training in laparoscopic and robotic liver surgery at leading institutes in France and Italy. He has organized, conducted, and chaired many national and international level conferences, delivered faculty lectures, presented and published his research work at scientific meetings and international journals. Welcome, Dr. Mohanka. Your topic is organ donation and transplant law, acts and rules, simplified and explained.
Thanks, Sunaina. Thanks, MSCI, for this opportunity. And give me a second. Let me start sharing my screen. Please let me know when you can see the screen.
Yes, we can see it.
Okay, great. So my job has been made easy by what Dr. Ashish's talk, because he's covered a lot of things. So we're going to start. And basically, this act was passed in 1994, like Dr. Ashish mentioned. But what was the situation of transplant before that? Because, the first kidney transplant became successful in the world in 1954 between twins. And since then, there has been a lot of activity all across the world, But just like India, most of these countries did not have a transplant law or act to support that activity. Now, when something is not regulated by law, it's not illegal. So there was technical ability to do a transplant before 1994, but there was no law. So what happened is that there were surgeons who got trained in some of the Western countries. They came back and they started doing transplants in India, and unfortunately, most of it was living donor transplants, where one person donated one kidney and that patient underwent a transplant. And there was a lot of exploitation of poor people from villages in this process, and we got a lot of bad publicity globally for this. So what happened, there was like entire villages who had just one kidney, and this is a picture of a state from northeast where such a thing happened. So the point is that if you didn't have a law, there was nothing illegal in what was happening, but it was not right, or it was not like a ethical thing to do. And therefore, so this type of organ transplant where somebody donates an organ is called as organ trafficking when it is done for money. And therefore this is not ethical, and this is obviously looked down upon by everybody, all countries in the world. So this was the situation before 1994, when we as a country took note of this activity that was happening in our country, and passed a law to regulate transplant. Before 1994, there were rules and laws that were uh, in different states which regulated the activity of transplant in those states. And Maharashtra and Karnataka and Tamil Nadu were notable states who had such laws, but they were local. And remember that in India, health is a state subject. So there are some central subjects such as defense and all that, and there are some local subjects such as policing and health. So even though the center may make a law, each state has to adopt that law and accept that law, or they make their own law, and it is eventually governed by the law in that state. And does each state is not obligated to accept the law that is made by the center. This situation was also common in other countries such as Japan and South Korea, which have similar milieu like ours. And in all these countries, organ donation after death, after brain death, was very low or not just happening, because there was no way for us to certify somebody as who is brain dead as dead. So therefore, there was no organ donations or transplantations from brain dead patients, and all the living donor all the transplants were from living donors. And because there was no law, it wasn't illegal, but there was a lot of exploitation in this process. So the act was passed in 1994 after a lot of efforts. It almost took about 8 years of efforts, and some very notable doctors in Delhi were part of this effort. And then when a law is passed, you have to frame rules to implement it, design the forms that have to be filled and stuff like that. So they are called as rules, and that was published in 1995. So basically 1995 is the first time you could actually apply to a authority for getting a transplant done, or declare a brain death in a certain format and stuff like that, which we'll talk about. Now, very soon we realized that the act was outdated, because the field was progressing much faster than what we envisaged in 1994. And there were a lot of changes that were required to the law. And therefore, the process of amending the law, the changing the law, was started in 2011. And again, the amended law was passed in 2014, and the updated rules were published in 2015. So this is the chronology of the law, but I'm going to tell you now that it's due for another revision, although the process hasn't started, but there are still lot of gaps that have been identified, and there is interest in the ministry to try to amend this law again. Now, there are a couple of things that the law did. I'm going to talk about both the original law and the amended law together, so that you'll only know about the updated and the amended law, and not the historical thing. So there are two things that the law did. One was to define brain death and accept it as a form of death, and doctors could now certify brain death, and it will be like any other death that is there. Now, the process of declaring brain death is very different from the process of declaring death like we know it. So what we typically know as students and as doctors is, when the ECG is flatline, that is when the person is dead, and that was called as cardiac death in the past. Now it is called as circulatory death. Dr. Ashish talked about that, you could even do organ donation after circulatory death, but we are not doing it right now. But anyway, even let's talk about brain death first. So when somebody was declared brain death, then you could take consent for diseased organ donation or cadaveric organ donation. Now, this was possible because of the law recognizing the death as the brain death as death, and who could give consent for organ donation in such a situation. So one could actually consent for organ donation even before their death. For example, you could sign a donor card, and that would serve as a consent for organ donation, although that's not legally binding. It has to be done in the presence of two witnesses. Or after death, a person in lawful possession of the body, generally it's the next of kin. In case of married person, it will be the spouse or children or parents, depending on the situation. In case of unclaimed bodies, it will be either the hospital in charge, or if the body is in prison, then the prison in charge. So after somebody is declared as brain dead, then there could be a consent process for organ donation, and this was the process was laid out. Now, this is a donor card which is there in different countries, and in our country, the various organizations have also published donor cards, including Organ India, and NOTO, which is the national body, also published donor card. So how do you declare brain dead? This is also laid out in the rules, and basically what it means is that the person has to have irreversible permanent damage to the brainstem. Now we know that brainstem controls your respiration and circulation. Now, even if there is damage to the rest of the brain, it doesn't mean that the person cannot spontaneously breathe or continue spontaneous circulation. Like you may have obviously heard that there are people who are in coma for many, many years. Now, those are the people who have permanent damage to the brain, but it is not the brainstem. And in that situation, they can be alive and for many, many years. But if there is damage to the brainstem, then the vital structures or control of respiration and circulation is lost. And in that situation, it is an irreversible thing. So therefore, how do we test for damage to the brainstem? Because all our reflexes are controlled through the brainstem. So you'll have dilated pupils with no reflex to the light, the corneal, gag, cough, all these reflexes will be absent. But the final test is what is called as apnea test, which means that even if you increase the CO2 level to more than a certain threshold, and there is no spontaneous respiration, then the person is not going to breathe without a ventilator. So the person is ventilator dependent. And that is tested by disconnecting the ventilator for a minute and doing a ABG. And if despite the CO2 going above a certain level, the patient does not have spontaneous respiration, then they are considered as brain dead. Now, to safeguard the practice, the law prescribed that it has to be done twice, and it has to be done at least 6 hours apart. and it has to be done by a medical board, which is sort of recognized and certified to be able to do that. Obviously, we have to exclude things like hypothermia, metabolic derangements, and drug toxicity, which can mimic a brain death or have similar picture. So therefore, this was very clearly defined. There is probably no other country which has a law which prescribes how a brain death certification should be done. They're all standard practices that everybody follows, but we made a very stringent and a very good law, and it has worked. The second thing was to regulate living donor transplants. Now, for like we know, the living donor transplant was where most of the exploitation happened before the law was passed. And the law defined that a living donor has to be a major, cannot be a minor, and has to be preferably from a near relative. Now, near relatives was also defined as who is a near relative. So it's spouse, grandparents, parents, siblings, children, and grandchildren. So spouse and blood relatives. And there is a regulatory framework which was defined as to who will regulate what. So appropriate authority was appointed by the state, which will give permission to hospitals and monitor the hospitals for any problems and do it on a routine basis. Generally, every 5 years, they will monitor the hospital for their license for transplant. Then there is authorization committee, which will actually look at all the living donor transplant applications and will give permission for each transplant. So it's unlike any other surgery that you do. If you want to do a hernia surgery for somebody, you don't have to go to an authority to get permission. You can just schedule the case and go ahead. But for transplant, each case has to go to what is authorization committee, who will verify that the donor and the patient are genuine relatives of each other, and they will verify that there is no financial transaction happening between them, and only they then give the clearance. And then, like we discussed, for brain death certification, there is a medical board who will know exactly how to do this brain death certification. Now, they also defined what are the requirements for somebody to become a transplant center and what is the process. So this is in the rules, where the facilities, the equipment, the manpower, qualifications of manpower and transplant coordinators, everything is defined. The process of consent is also defined. So the authorization committee proceedings are video recorded and they're kept for 10 years. The cost of transplant has to be displayed on the hospital's website. And then there is a new concept that was introduced in the 2014 amendment, which was NTORC, which was non-transplant organ retrieval centers. So there are several hospitals that have transplant facilities, but there are several more hospitals that do not have transplant facilities, but they could be places where brain death will happen. And those are called as non-transplant organ retrieval centers. And the minimum requirement for them is that they should have at least 25 beds. So even a nursing home will qualify. They have to have a ICU and a operation theater, because that's required for maintaining the donor as well as for retrieval of organs. So these are all defined in the Transplant Act and the rules now. Also, to monitor the program and how to take it forward, a national organ transplant program was mandated in the new rules, which was an advisory committee was set up by the government of India for under the aegis of Health of Ministry, and a national human organ and tissue removal and storage network, in short called as NOTO, was set up. Now, NOTO is a national body. They work through different regional bodies called as ROTOs and state bodies called as SOTOs. And that was all put in place. Then a national registry of donors, potential donors. If somebody signs up for an organ donation, there was a national registry which was made, and a recipients waiting list, also called as registry, was also set up for patients who are undergoing a transplant. So all this was put into place after the law was enforced. Now, the offense for this was also defined clearly, and it was quite significantly increased in the 2014 amendment. So any removal of organs without authority is 10 years of jail time and a fine of 5 lakhs. Removal of organs without authority by a doctor, first time deregistration for 2 years, and second offense is permanent deregistration. And commercial dealing in organs or falsification of documents has 5 to 10 years of jail time and 5 to 20 lakhs fine. And any other violation of the act was 5 years of jail time and 5 lakhs fine. So quite significant penalties were enforced in this. Now, as a result of this, like I said, even before the act was passed, there were some transplants done. But after the act was passed, a lot of transplants were first time done in India, especially liver and heart transplants were done. And then this really led to a big increase in the number of transplants across the country. Having said that, we still have very little, compared to the rest of the countries, very little number of organ donations comparatively. So how do you measure organ donation across countries is, and compare them, is what is called as donations per million population. So this is the map for different countries, and there are countries that have more than 40 donations per million population. And in India, we had about 1,000 donations last year for a country of 1.4 billion. We are less than one donation per million population. So we still have a long way to go. Although there have been improvement, this is something that Dr. Ashish also spoke about. This is an older graph, but this is pre-COVID, because COVID made a lot of difference to how things went. But we've continuously, progressively grown in organ donations every year to more than 1,000 now, like I said. But it is grossly insufficient for the number of patients that we have and the number of organ transplants that are required. So I think what the law very successfully achieved is it created a system for registration of hospitals for transplants. This was a very successful thing. In the past, you would, have, and you may have heard this, but people were doing transplants in some small, really make-up nursing homes or hospitals, and there were like scams to this effect. The second achievement of this law was that the regulatory and the enforcement agencies for monitoring and for implementation of penalties has been very effective. So it is rare for us to say this in India, but the Transplant Act has been very effective in its intent, and it has been really well implemented and regulated, enforced. So the organ trading to a large extent has been actually eliminated from India. You still hear an occasional scam somewhere, but to a large extent, most of the transplant activities that are happening in India are all ethical and very well monitored. But again, the need is much more than what we do currently. These are again old numbers, but the kidney transplant numbers are close to 12,000 now. The heart transplants are about 200 now. The liver transplants are about 4,000 now. But the gap still remains. So the big gap is still unfulfilled, and there is more that we need to do. And what is it that we need to do is, we currently leave the brain dead declaration to the clinician who is taking care of the patient. Now, the problem is that because we don't have a very good level of trust between the doctors and the patients and their families, brain death, most doctors in the ICU are slightly reluctant to declare brain death, even if the patient is clinically brain dead. So if a person who is clinically brain dead is not certified to be brain dead as per the act, then there is no organ donation going to happen. And therefore, it is important that we make brain death declaration and reporting mandatory. Once that is done, then it probably will increase the organ donation rates much more. So it should not be optional, right, like it is now. It should be mandatory. If there is a person who is clinically brain dead, we should be mandated to declare it. Second, like Dr. Ashish again mentioned this, that training in brain death certification and donor maintenance for doctors is not very common, and education has to be done. The third problem that we face is, sometimes there is a medical legal case, an accident, which is a common reason for brain death. And in those situations, there has to be a post-mortem done. At the same time, there is organ procurement to be done. Of course, if you try to do both, then the organs will not be usable. So there are different states that have come up with very innovative solutions where the forensic expert comes into the operation theater and looks at the organs at that time, and then the body is sent for postmortem later. And several other solutions have emerged in the last few years in states which do a lot of organ donation and transplant. And one of these could be stipulated as a law in the future to solve this problem also. So there are several problems, but there are several solutions. And the last thing that Dr. Ashish also spoke about is the donation after circulatory death. So just to sort of give you a perspective, like Dr. Ashish said, about 10% of all patients with brain damage progress to brain death. 90% don't. But if you look at overall deaths, only 1 to 2% of people who die, they die of have brain death. 98% have some other form of death, right? Circulatory death, either a cardiac problem or some other problem leading to that. Now, if a lot of countries have made a lot of progress in this, and there are countries that have 50% of their donations are by DCD now. And I think this is the big potential that we have in India, because one is that although brainstem death may be more difficult for people to understand, heart stopping and person being dead is very well understood by the population. So this is where we can focus our energies on. There have been several technologies that have become available in the world in the last 5 to 10 years, which have transformed the field of DCD, and the outcomes of DCD, which were inferior to brain dead donor transplants in the past, are equivalent to those of those now. So I think we have to, the next amendment of the law is due, and these are the things that we can include in those. And just like having a clear, crisp definition of brain death in the law, if we can lay out, if the new amendment can lay down the pathway for how a futility of care is defined, how withdrawal of care is done, and how donation can be done after circulatory death, it will go a long way to increase the number of organ donations in India and transplants in India. Thank you very much.
Thank you so much, Dr. Mohanka. Does anybody have any questions before we move on to the next speaker? Or we could take the questions a bit later if Dr. Mohanka is still there.
Sure.
Yeah. All right. So our next speaker is Dr. Jitendra Sharma. He is Chief Critical Care and Chief Medical Quality at Artemis Hospital, Gurugram. He has done his MD in anesthesiology and several fellowship courses in critical care, specifically Fellowship of Indian College of Critical Care, Medicine FICCM, and Indian Fellowship in Critical Care IFCC. He is one of the leading critical care experts in Delhi NCR and has won many awards for it. He is the editor and co-editor of many books on critical care, such as Atlas of Critical Care and Textbook of Critical Care, first and second edition. Dr. Sharma is also holding the position of Chairman of Critical Care Society of Gurugram. He has won several awards such as the ISCCM Presidential Citation Award 2019, 2021, and 2022, COVID Warrior Award in 2020, Best Critical Care Expert in Delhi NCR of Indian Healthcare Award in 2014, and Hansraj Nair Memorial Award for Best Paper in February 2009. His topic is identification of potential donor and brain death certification of donor. Dr. Sharma, welcome.
Thank you, Sunera, for kind introduction. Am I audible? Yeah, my slide is visible.
Yes, you're audible.
So, my job is almost done by our two previous speakers, Dr. Ashish and Dr. Ravi. Brain death declaration as a part of the pure scientific knowledge. Previous lectures, we understand the magnitude of the problem, some cultural aspect, emotional aspect, and of course the science behind that, and the core data is over there. Now, brain death declaration, the basic principle are all the now budding doctors knows. This talk will be more towards the scientific way to pronounce brain death. Initial concept, there may be a repetition, so I'll skip a little bit part over there. And why there was a change. Initially, the clinical death is defined legally as an irreversible cessation of all vital functions, especially as indicated by permanent stoppage of heart, respiration, and brain activity. That was a classical definition. In India, the brain death, this concept came in 1994, where the section 46 of the Indian Penal Code states the word death denotes death of the human being unless contrary appears from the context. And Transplantation of Human Organ and Tissue Act 1994, that declaration of death by brainstem death criteria has been given a legal recognition in India, and that specifically for the transplantation of the organ. And later on, Dr. Ravi has emphasized it, legally also we bound to pronounce the brain death irrespective to the whether we are going for the organ donation. So for the basic scientific principle behind the brain death is these three main pillars. One is irreversible coma, and it goes in that fashion only. First, one has to establish coma, and that too is irreversible. So most of the concept we'll see, to really make it irreversibility, we have to have certain prerequisites. Once it is clear the person is having coma and that too is irreversible, then we'll go for the absent brainstem reflexes demonstration. So brainstem reflexes would be very much familiar for our young budding doctors. It is a purely their physiological knowledge of the cranial nerve examination. We'll discuss subsequently. And lastly, we'll go for the apnea test, where it is a procreative test. That's why it has to be done in the last. And the things happens in this way only. Once you completely these three pillars are met, then only you can pronounce brain death. If something cannot be done or may not have opportunity to or may not be demonstratable, there would be a certain a remedy for that, certain solution for that. This is the classical diagram. If they remember, our first talk already explained about that, how the brain death happens. Actually, the uncontrolled cerebral edema happens, whatever the cause, and eventually that lead to the permanent brain damage and the brainstem is lost. What are the common scenario? And what situation? Because most of the person, they think any critical ill patient would be eligible for the organ donation, or any neurological patients or having a coma would be eligible for the organ donation. So what are the common situations? Classically, the trauma, especially the head injuries. These are the classical one which we are seeing over there. Cerebrovascular accidents like intracranial bleeding, subarachnoid hemorrhage, or massive thromboembolic stroke, acute encephalitis and brain tumors, and hypoxic ischemic injuries. And they must be sufficient to cause the insult to produce a permanent damage and irreversible coma to the patient. So these are the usual situations which we come across. Now, criteria for diagnosis, prerequisites, as I told you, most of the prerequisites to establish this, either the coma or this coma is in irreversible nature. The cause of brain death should be known, and the neuroimaging evidence of a catastrophic brain condition compatible with the clinical diagnosis of brain death. What does it mean? Of course, one must have a documented brain injury, and that injury is shown in the neuroimaging sufficient enough to cause such a vast devastating condition of the brain. Exclusion of confounding factor or medical condition. So this point actually to establish the irreversibility. There should not be any confounding or reversible factor which can produce the coma, and that would be reversible in nature. No drug intoxication sedation. Core temperature has to be more than 36 degrees centigrade, because hypothermia known for the reversibility in the coma. Even the cardiac arrest can be reversible in the severe degree of hypothermia. An exclusion of brain death mimic like acute inflammatory polyneuropathies, Guillain-Barré syndrome, snake bite, that is a neuroparalytic snake bites. And systolic blood pressure should be more than the 90 to 100 mmHg. Why? Because the a critical lower blood pressure can also alter the sensorium out there, and it may confound your establishment of the coma. The clinical criteria are the mainstay of the diagnosis, diagnosing brain death with laboratory tests needed for confirmation in the presence of confounding factor. What does it mean? It means that most of the time, you don't require any specific test for the pronouncing brain death. Of course, the neurological test would be required, but from afterward, most of the things would be clinical in nature. Under a certain situation, you require a certain test. Loss of cerebral function should be compatible enough. Sometimes some movements originate from tactile stimuli or spontaneously from the spinal cord may still be present after brain death. This is quite interesting, especially the general population or sometimes even all doctors are not aware about that. Some spine reflexes and some movement can be noticed over there. And this is the list over there. These are the very well compatible with the brain death. That means one can notice facial twitching, facial finger twitching, arm pronation, tonic neck reflexes, what we call is the Lazarus sign. It looks like the people must have heard, suddenly that person sits up. So these are the typical movements and they are spinal nature. This is compatible with the brain. Truncal movement, abnormal Babinski, and undulating toe sound. So neurological criteria further, of course, the one was coma, irreversible. Now loss of brainstem reflexes. We'll see what are the reflexes over there. There's typically the cranial nerve examination. And the lastly, the apnea test. So these are the three things over there. And this cranial nerve examination intended for the establishment of the absent brainstem reflexes. What is the principle behind that? Almost all the cranial nerve nuclei situated around the midbrain, lower part of the midbrain, or the upper part of the bones. So if clinically you see all the cranial nerve is not executing their reflexes, that means all the nuclei, they are very much situated very closely to each other. Then you almost it determines the brain stem is not working. So that's why these are reflexes. Our young colleagues are very much familiar about that. They otherwise we can perform in the in our neurological examination with the intention to diagnose a certain disease and finding, and sometimes for the ophthalmological examination, sometimes for the ENT examination. But here, these cranial nerves, like a pupillary reflex, corneal reflex, I'll not go into the detail of the what are the ascending pathway and the descending pathway and the nuclei situated over there. But these are the most of the time you find the nuclei in the midbrain and the upper part of the bones. Oculocephalic, that is the Dolce reflex, and oculovestibular, cochlear vestibular, that is a vestibulocochlear nerve part, in which this reflex is elicited by the cold caloric test. Here, a specific procedure for that, the ice cold saline, about in adult, 50 ml is injected and wait for at least 1 minute, up to 3 minutes, and try to see any movements over there. Most of the people try, in this context, we are talking about the brainstem reflexes with the context of the brain death. It is immaterial where the nystagmus fast components towards the cold or towards the warm, because we are not performing the diagnostic. Any nystagmus, if the observer noticed, that means it is this reflex is present that go against the brainstem absent reflexes. So that means brainstem is intact. Gag reflex, cough reflex. So the importance of these reflexes, which I mentioned in the previous 3 slides, one has to perform all the reflexes. If there is a facial trauma, because the head injury may have a facial trauma also. So if you cannot perform any of this cranial nerve examination, then obviously you have to go for the accelerators. That is the main message I want to convey here. These are not the optional one. We have to check all the cranial nerve examination, which I mentioned in my last 3 slides. If there is confounding factor, say for example, somebody is having a severe facial trauma, you can't do the gag reflex. Somebody is having a severe temporal injuries. If you can't perform the cold caloric test, because cold caloric test has to be performed bilateral, then obviously you have to go for the ancillary test. So now we reach to our third pillar for the diagnosing of the brain death, that is the apnea testing. Again, remember, apnea testing is to be done in the last. After the you just prerequisites meet, suppose the prerequisite is not meeting, then you correct that. If hypotension, if hypothermia is there, then you increase the temperature. If significant acid-base disorder is there, then you correct it. Once the irreversible coma is established, then you go for the brainstem reflexes and then apnea test. And apnea test, typically, Dr. Ravi explained the basic principle behind that. In normal situation means, I mean to say, those respiratory illnesses which causes a baseline increased carbon dioxide. If we just keep these patients apart, if arterial PCO2 reaches 60 or more, then one has to trigger for the respiration. So that is a basic principle behind that. So once we adequately oxygenate the patient who is actually at this stage, what you call is a possible brain death. So you give the adequate oxygen and then disconnect the ventilator. How to go about that? So before that, again, you have to fulfill the certain prerequisites. Core body temperature has to be more than 36. Euvolemia and eukapnia has to be there. Systolic blood pressure more than 100 mmHg. Blood pH normal. There should be absence of hypoxia and prior carbon dioxide retained. And apnea test should not be performed when the subject is under the influence of paralyzing drugs. So these, once you fulfill all the requirement, then you go by the step by step. As I told you, you decrease the respiratory rate, increase the FiO2. FiO2 is the fraction of oxygen, and here it is understood all the possible brain death patient would be on the ventilator. So one cannot even think about any patient where they are talking about the brain death declaration, they would be off from the ventilator. They are on the ventilator all the time. And once we increase the FiO2 to the 100% oxygen and sufficient oxygenation happens. Why we are doing that? Because we are going to disconnect the ventilator so that body will have a sufficient reserve for oxygenation. Hypoxia should not happen during this process, and we disconnect the ventilator. With this principle, if there is no respiration is happening, carbon dioxide started building up in the brain. And you observe the respiration movements. So this observation for the respiratory movement with the hands on the patient chest, respiration is defined as abdominal or chest excursion. So here you not rely upon the just whatever oscillatory movements happen. It can happen with the cardiac impulses. You typically see the respiratory movement from abdomen and chest excursion. And the principle is this: if the intact brainstem is there, then the patient breathe within first few minutes. How long you will do that? How long you keep the ventilator disconnected? Obviously, at this moment, patient is live from the cardiac point of view. So everything is there, blood pressure is there, pulse is there. Even your pulse oximetry records the SpO2. So you monitor all these things as heart rate, rhythm, blood pressure, SpO2. And if it allows to keep this ventilation off, then your plan is to keep the ventilation off from 6 to maximum 10 minutes. During that period, carbon dioxide build up, and if you don't see any movement and the carbon dioxide before start, you perform a blood gas analysis that will give you a baseline carbon dioxide that is would be around somewhere 35 to 40 mmHg in the arterial blood. And once the 6 minute completes, then you withdraw one more sample. And if time permits, then you can prolong it. What happens? Either you'll be able to perform it and you may not be able to perform it. A patient may showing a hypoxia, blood pressure goes down, then you have to abort it. And these situation, how you interpret the apnea test? If you successfully perform and the second blood gas you did after the disconnection of the ventilator, as I told you, 6 minutes to the 10 minutes, whatever longer you can do that. And the PCO2 crosses 60 and you don't see any movements, then it would be a positive test. One rider, it is a rise more than 20 mmHg from the baseline. This rider is for those patients who are already having a baseline PCO2 more than 40. Some COPD patient is having a baseline PCO2 70. So right from beginning, they are qualified for the apnea test positive? No. And for them, it is a 20 mmHg. Otherwise, the test which having a baseline PCO2 30 and after that it becomes 50, it won't qualify for the apnea test. So 20 mmHg is from the higher side of the baseline. Otherwise, 60 would be a classical number over there. If you see the movements, then the apnea test is negative. And of course, at that moment, the patient is not the brain dead and you continue your care. Third thing is you can't perform the apnea test, neither you get the desirable time and the PCO2, and before that you have to abort it. Then it is called the indeterminate result. And indeterminate and strong clinical ground to suspect apnea present, then the correct parameter and repeat the test. Otherwise, we can go for the answer rate test. So there are certain contraindication to apnea testing, like a hypotension, systolic blood pressure less than 90. As I told you, those patients mainly from the trauma, head injury, and polytrauma also there. The patient may be having a chest injury also. And that chest injury is not allowing for the apnea test because the oxygenation is already hampered, ARDS or great lung contusions or lung injuries. Then the arterial oxygenation is already hampered as a part of their disease process or the trauma process. Then you can't perform the apnea test or severe acidosis. In these situations, we can go for the another answer rate test. I'll talk about that in the subsequent session. And sometimes it may not be possible to undertake apnea testing in patient with the high cervical cord injury or patient with the poor aquiescence. So high cervical cord injury is actually completely paralyze the patient. That's why they will not show any respiratory movement, but the brain is intact. So that's why in this situation, you go for the answer test. I'll talk about the answer test subsequently. Before that, we assume, suppose everything is in the direction of the brain death declaration in the form of apnea test is positive, then it is a standard practice to repeat the entire process by team of doctors. So what they do, they examine the patient, perform the apnea test, then again it would be repeated. And the reasonable period for the time for the repetition of the test, the second test is the 6 hours. And apnea test is the final to be done. At the end of the apnea test, there is no ventilator response and precondition for the clinical diagnosis of brain death have been satisfied. The patient is declared dead and time and date is noted. This is the official time. There would be a certain question comes into the mind. What should be a time of death we should record in the death certificate? So it is a completion of second test. So classically, all hospital who are having such type of the patients, whether they go for a transplant or not, that's a different issue. They must have their own institutional protocol, obviously based upon the what are the classical one suggested by the not only the standard science, by the legally you are bound. I'll show you a copy of that form one has to fulfill. Now the one subset which I talked about in my in between talks is the ancillary tests. What are these tests? These are not required as per Act in circumstances where apnea tests can be performed. So these are not optional over there. You go for apnea test or you can't go for the apnea test, then only it can be done. But it is not the option for the clinician. So they can't avoid the apnea test where it is feasible and go for the ancillary test. This is not the law says. If you're going for the ancillary test, then you must actually document why the apnea test cannot be done or it was indeterminate all the time. So situation where ancillary test may be required, the confounding factor make results of apnea test unreliable, like a sedation paralytic agent may not have cleared from the system, and now the organs becomes the most precious things. When you wait for all the medications effect wears off and that patient become unstable, then probably you lose the organ also. So in that situation, if prerequisites are not met and the patient is very prime, then you can shorten your things with the ancillary test. Apnea test could not be completed, shorten the duration when cranial nerve are difficult to examine, as in the severe facial-maxillary injuries, and infant less than 1 year, we go for the ancillary test. What are the ancillary tests? The list is the either EEG, brain blood flow. It can be demonstrated by the transcranial Doppler, 4-vessel CT angio, MR angio, cerebral angio, brain perfusion by the radionuclide cerebral perfusion test. So any of this test can be done. So that part was the scientific part. Now coming to the legal part of the declaring of the death. So diagnosis of brainstem death is required to discontinue artificial ventilation and to ask a legal consent for organ donation from birth. So initially, Dr. Ashish actually mentioned about the other form of the organ donation apart from the brainstem death. But in India, as if now only brainstem death is allowable for the organ donation. Of course, immediate after the cardiac arrest can be done. End of life or end of life kind of situation, as if now is not permitted by law for the organ donation. So the only way to go for the cadaveric organ donation is the brainstem death legally. So the 4 medical experts required for the examination of the patient and apnea test. So who are they? One is the registered medical practitioner in charge of the hospital in which brain stem death has occurred, administrator. The law, these are the legal RMP, means whosoever is clinician actually, who is taking care, and one doctor, at least one doctor from the approved by the appropriate authority for brain death declaration. Which is the appropriate authority? As of now, the NMC, which actually clear the certain clinicians based upon the requirement as a brain death committee members. So one has to be there in the committee, and the neurologist or neurosurgeon nominated from the panel of the name approved by the appropriate authority. So neurologist or neurosurgeon either from the brain stem death committee can be there, or in the absence of the approved brain death committee, then the NA neurologist or neurosurgeon can be there. And the treating doctor, who is the primary disease which actually produced the brain death in the certain situation. And this is the form which one must fill in the condition of the brain death declaration. Now, at this point, everybody must be very clear. The certification of brain death is required irrespective to the whether the patient is going for the organ donation or not going for donation. So when prerequisites require, you start doing all the examination and the after the forming of the committee, and all the details has to be mentioned. And this is the form where all your finding of the cranial nerves, reason for coma, and all these things are the part of the legal documentation also. So this is the not only your medical record, it is a medical legal record. So we have to. And lastly, signature of all the 4 persons, which we already discussed. Little bit a change in the observation period based upon the age of the patient. Like if neonate, then the 24 hours. You remember in the adults, we talked about the at least 6 hours apart, we have to do 2 sets of the examination. That means all the time you have to go for the cranial nerve examination and all this thing, and apnea test. For infants, that time duration would be at least 12 hours. This is the, so what is the flow of this possible or identify cause of coma? Exclude confounders. Once you exclude confounders, perform brainstem reflexes. Then go for apnea test. Follow institutional protocol to certify brain death. What can happen? Possibly some may not be able to perform the apnea test or whatever the reason, then go for the ancillary test. Ancillary test is in favor of the absent brain reflexes, then again follow the institutional protocol and manage the patient as a potential organ. So this is the way, and of course the management will be taken quickly. The few frequently asked question will give you a more clarity. Is it necessary to have organ transplant program in hospital to certify brain death? No. Just any hospital who is having, of course, ICU facility or a ventilation facility, and ABG is a must for that. Can panel of any 3 doctor plus 1 neurologist certify brain death? No, at least 1 member must be from the brain death committee. Who can be part of brain death committee? This is the as if, but these things keep on changing, and now that little bit more liberal in terms of the situation, because unnecessarily loss of organs. So these are the criteria keep on changing for that. What happens if brain death is certified and patient family is not willing for organ donation? Declare death after secondary test, disconnect ventilator, and you certify death. Should we mention about brain death or organ donation in death certificate? No. The death certificate will not be any change from the any other death which you are pronouncing or declaring in any other medical condition, except you find one common thing in the all the brain death certification would be a cause of death would be severe brain injury. Otherwise, it won't differ. What should be time of death? Second completion of the second apnea test. Can we substitute tensor test by clinical examination? No, we can't. What should be done in situation with severe metabolic acidosis, attribute to the AKI or CKD patients, somebody on the dialysis anyway, and encounter the situation like a brain death? Then dialysis has to be done, and once the parameter acceptable, you can go for the brain death. So this is very important, and in our textbook of critical care, which is one of the co-author for this textbook, we include one whole chapter for the brain death and support of the brain death organ to actually facilitate as well as the uniform training of the on the intensive care for the brain death declaration, because the intensivist is the main founder, or you can say main person for the declaration of brain death.
Thank you so much, Dr. Sharma, for this wonderful talk. We have asked for questions, which we can take after the next talk, if that's okay with you. So I would like to introduce the next speaker, and that is Professor Kajal Jain, Department of Anesthesia and Intensive Care, PGIMER. She is has been an academic anesthesiologist for 30 years and is founder of the first national academic body, Society of Trauma Anesthesia and Critical Care. Dr. Jain has been actively involved in deceased organ donation program with Roto North and has supervised more than 250 potential donors in the trauma intensive care unit jointly with transplant and neurosurgical teams of PGIMER. She has been participating in outreach programs, monitoring nearby states and institutes for deceased organ transplant program with Roto North and PGIMER. As part of that, she is here today to speak on donor maintenance, preservation of organs for retrieval and transplant in ICU. Welcome, Dr. Kajal.
Thank you so much, Sunaina. And is my screen visible? Just wanted to ask you. Is my screen visible?
No, I mean there is a camera.
Yeah, that's it. Can you just make it? I mean, like, let me just make it full screen, and I'm not able to get hold of the full screen somehow. Okay, yeah. So, just let me know if my screen is visible.
Yes, fine
Yeah.
now. Thank you.
Yeah. So first and foremost, I will just like to thank Organ India as well as all the students who have gathered together to listen to this very important topic today. And I will be talking about how to ensure optimal donor management in ICU. So I'm sure there'll be some overlap, and I'm sorry for that because the topics are so intertwined that some of the things may be, common. So I'm an intensivist by profession, and an anesthesiologist and an intensivist, and I look after trauma intensive care of my hospital. And just a moment. I'm not able to move the screen. So this is not, yeah. So what I want to tell to the students here is that we all look after intensive care patients in our ICUs, but sometimes the best of efforts also save to fail. And in those situations when your best efforts are failing, we can, think of organ donation. And because for somebody it may be tragedy, but it may turn out to be victory out of tragedy for the others. Because we all know that in India, we have the list of patients who are waiting for organ transplantation is very high. And patients, they die while waiting for organ transplantation. And then Therefore, it is recommended that organ donation as an option in the end of life for every ICU patients should be given. And also, on the other hand, we must also realize that we are looking for organ donation, but so many potential donors are refused because of suboptimal quality. And the most important organs which suffer this suboptimal quality are liver, lungs, and the heart. And that is why, if you are very alert to the management of these patients early on, you can contribute to a bigger load of organ donor pool rather than just going ahead with 1 or 2 solid organs. So the majority of transplanted organs, they come from donors after neurological determination of death, which you just heard from Dr. Jitendra, like how to identify after apnea testing the neurological determination of death. And other forms of cadaveric donations are when the patient has a bleeding heart, beating heart, that is cardiac death donors. And then, of course, there is live-related and unrelated donors. So we have all heard in the last lecture that figuring out brain death is not a guessing game. It's a very much clinical diagnosis. And clinical diagnosis is based on 3 important cardinal features. That is the irreversible coma, absence of brainstem reflexes, and then finally, what clinches it is the apnea test. So where all this goes on? This goes on actually in an intensive care unit where you recognize among those who are severely sick and critically ill, who are the ones who are not now having a survival because they are now brain dead. And once you identify, you protect their further organs from deteriorating, because I just said the quality of organs should be maintained. And therefore, along with that, how do you protect them? You have to optimize them. Both of them are linked together, and all these things go in hand in the intensive care unit. So therefore, the role of intensivists is paramount. So this slide is a repetition, because how do you, zero down to patients who are brain dead? So we've already heard Dr. Jitendra in the last lecture that there are certain prerequisites. Like if you get a call, say from your triage area, or your patient is well within your ICU, you must check whether the patient has an irreversible coma or neuroimaging. As you can see here, the neuroimaging itself is explaining irreversible coma. There is no residual effect of sedatives and no severe electrolyte imbalance. The temperatures aren't very low, and patients' hemodynamics are maintained beyond 100 mmHg of systolic blood pressure, and patient doesn't have spontaneous respiration. These are the prerequisites, and we have all heard how these can impact or how these can become better if you resuscitate them. There have been so many instances when my residents have informed me of an M1 status which became M4 or even M5 once these abnormalities were corrected. So hence it is very, very important that all the prerequisites are properly checked and confirmed. After that, you can do the examination, which will depict, the brainstem functions, which are typically seen as your non-reacting pupils. The corneal reflexes are absent. Oculocephalic and vestibular reflexes are absent, and then there is no response to the supranormal stimulus which you give at the supraorbital nerve or temporomandibular joint, and then you see the gag and the cuff reflex, and no motor response. All these things are checked in the intensive care unit before you perform the apnea test, which is the final test which certifies the death of the patient. So this is a very important slide. And then, as an intensivist, to make the patient, subjectable to your apnea testing, we have to optimize the function and viability of all transplantable organ. This is at the onus falls on the intensivists, because we have to improve the number of organs as well as the donors, and subsequent graft function. Very important. So whatever management you do intensive care also tells you whether the patient who gets the transplanted organ benefits from it or no. based on your management. And of course, as intensivists, we have to facilitate brain death examination. So what actually happens when the patient has a loss of brainstem function? So if there is a catastrophic head injury, for example, and the patient's ICP rises beyond limits, then the patient herniates, and there is a ischemia of the brainstem, which leads to a lot of systematic physiological instability. And the most pronounced among those systemic physiological instability is initially it is hypertension, which you see and interpret as Cushing's triad, and later on, as the ischemia descends below the medulla oblongata, hypotension appears. So more than 80 to 97% of patients, they are seen as vasoplegic, hypovolemic, and they also have myocardial dysfunction. So this myocardial dysfunction, which you must have read during your entrance examinations, is a stress-induced myocardial dysfunction, also known as Takotsubo's cardiomyopathy. So these patients have this intense hypotension, and they are also very prone to cardiac arrhythmias because of catecholamine release and myocardial injuries. And then there is loss of temperature regulation because of the hypothalamus pituitary axis malfunction. And then that also leads to hormonal imbalance, diabetes insipidus. If you do not treat all these things and the patient is subjected to prolonged arrhythmias, this patient can have a cardiac arrest. And it happens very often because these patients are extremely unstable. If you do not take care of all these factors, which I'm going to talk about in the subsequent slide, then you stand to lose vital organs which can be transplanted into any patient. So as I said, hemodynamics is a very significant component. And as soon as you receive an organ donor in your intensive care, the dynamics of the ICU also change. The patient has to be put on multiple infusion pumps, which run with very critical drugs running at a very high, very important rates, and it needs to be monitored very vigilantly every hour. So as I just said, that due to the massive sympathetic storm, arterial blood pressure and afterload increases, and it causes cardiac damage due to the endothelial damage. Pulmonary capillary pressures and increase beyond limits, which cause pulmonary vasoconstriction, causing left atrial pressure. And again, this kind of autonomic sympathetic storm follows the vasoplegia, which I talked about earlier. So the patient is very, very unstable. There would be times when you would see the pressures are shooting up, and then the other times you would see that the patient has suddenly crashed down. So along with this, if your patient is a case of trauma, then you may also see that patient has suffered significant blood loss from the previous trauma, and patient may have received fluids, but they may not have been adequate, so inadequate fluid resuscitation. Or on the flip side, if patient has received large volume resuscitation, then the oncotic pressures can drop drastically, so the patient will be having will not hold the blood pressure because of that. And in certain cases where the patients are a case of head injury, they would be receiving diuretics or your osmolar therapy using mannitol. So the endocrine changes may also contribute to fluid depletion and vasoplegia. So clinical assessment of volume statum becomes even more challenging in a brain death versus a general ICU patient because of the three reasons I have just cited: the central sympatholysis, profound peripheral vasodilation, that is vasoplegia, and development of central diabetes insipidus in these patients. So you do not know how to bring up the pressures in these patients so many times. What do you do then? You have to target a hemodynamic goal. That means you have to keep a map of at least 60 to 70 mm Hg and try to target an ejection fraction of more than 45 degrees. There is no evidence from RCT or any superiority of any regimen over the other, but we have certain, guidelines. So how do you choose your vasopressors and inotropes? So for choosing your vasopressors and inotropes, you have drugs like norepinephrine, which are potent peripheral vasoconstrictors, and then you have vasopressin. And in certain situations, you can even think about dopamine. But when you use dopamine, you have to be very mindful of the fact that higher doses of dopamine are arrhythmogenic. So we do not advocate the use of dopamine in the first place unless there is a overriding need to do so because of kidney transplants. Otherwise, the go-to drug is mostly norepinephrine, and this has come from a retrospective trials where they studied 135 cadaveric donors who gave 270 kidneys to the various donors, and then recipient of these kidneys were evaluated. They found that increased number of noradrenaline infusions days was associated with decreased rates of graft rejection and graft loss. So that is what we are targeting at. We also want to see whatever organs we are giving, are they going to benefit the donor or no? So we have to use those drugs which are beneficial for the donors in the long run. But be mindful of high doses of norepi, because high doses of norepi are prone to cause pulmonary capillary permeability, extensive mesenteric or coronary vasoconstriction and afterload. So it may not be very beneficial for brain death cardiac donors. Small prospective trials have shown that there are reduced end diastolic elastins, worse cardiac graft functions, and worse survival at 1 year in heart transplant patients. So it's always good to add another drug. So what is the other drug you can add? So vasopressin can be used as the first or the second line vasopressor in patients who are hemodynamically unstable. So vasopressin are run in the pressor dose of 1 to 2 units per hour, and it has been shown to stabilize the vasodilatory shock caused by brainstem death. In addition, when you use low dose of vasopressin, it also counteracts the central diabetes insipidus. It helps to restore vascular tone by stimulation of V1A receptors, and hence they also help you to reduce the doses of norepi or epinephrine. So this is the drug which we are also currently using in our ICU, as the patients, supranormal doses are not beneficial in these cases. Along with this, since we are all getting a hang of using ultrasounds in our ICU, I would recommend that the younger generation should start learning serial echoes along with for hemodynamic monitoring. Of course, you can go ahead with CVP monitoring also if you do not have a hands-on on ultrasound. CVP can trend your CVP pressures and tell you how to go about your subsequent management. Along with this, you can also send your ABGs for lactates and central venous oxygen saturation, which can give you a picture on tissue oxygen perfusion and whether the organs which are going to be transplanted are not in hypoxia or hypoxemia. So what should be using as volume expansion? We have talked about the drugs. In volume expansion, we are not advocating the use of sodium chloride because most of these patients, by virtue of central diabetes insipidus and neuronal damage, are already having hypernatremia. So the main thing to do in intensive care is to bring down your hypernatremic values below 155. That is the cutoff. And most of the times when we receive these patients, the values are as high as 170 to 180. And we all know, with the first slide said, in patients who are having extremes of electrolyte disturbances, you cannot go ahead with brain death certification because that is a confounder. So you cannot give sodium chloride in these situations. So mostly we prefer to do correction of hypernatremia using half normal saline with free water correction. If at all you have to use any fluid, you can use balanced salt solution. And we are not advocating the use of HETA starch because HETA starches or colloids are associated with graft failures, particularly in the renal settings. So if you have to do volume expansion and maintain euvolemia, it would be good to go ahead with the balanced salt solution. And if the sodium levels are very high, then you can do free water correction with using half normal saline and dextrose. So at the same time, there is a big challenge, because on one hand side, you want to hydrate the patient well enough because the kidneys have to be in a state of good perfusion. And when you give aggressive fluid management, it may not be very conducive to a patient who has to undergo lung transplant. So you have to strike a balance whether a conservative fluid replacement is good or aggressive fluid management is better. So retrieval rates are all dependent on your these kind of optimization strategies. If your patient is a candidate for lung transplant, then I would suggest that you keep the patient on isobalance and not fluid overload the patient, because that is detrimental for the patient who is going to receive lungs. So in a cohort study of lung targeted management strategy, restrictive fluids had no adverse effects on kidney graft survival. So that is reassuring for all of us who are, skeptical about how to manage fluids in patients who are undergoing both, who will receive lung transplant as well. So when we talk about blood and blood products, we can keep the hematocrits at least at 21%. That is a hemoglobin of 7. And I wouldn't hesitate to say that I even go beyond that. Sometimes I ask residents to bring it up to even 10 if patient is not maintaining hemodynamics. So lungs are highly susceptible to injury because of the catecholamine storm I have already told you. And then there is an inflammatory cascade which ensues because of the neurogenic pulmonary edema. Along with that, don't forget your patient has been in intensive care unit and patient may be having pneumonia, atelectasis, ARDS, chest trauma, and showing signs of aspiration. All these things compound your lung injuries, so much so that, as I'd already said, that suboptimal management contributes to, the loss of one organ for transplantation. So we have to be very careful about this, and we have to manage chest x-rays. As you can visualize here, it is fully fluid loaded, and then you have to clear this space so that patient can be taken for lung transplant. So all these things, they impede the potential lung donation, and it also endangers homeostasis of other organs because they do not get proper oxygenation. So what do? You do lung protective strategies. You try to target an arterial blood gas of more than 100 mmHg. You also try to maintain saturation more than 95. You keep your peak airway pressures lower because you don't want barotrauma. And then you keep your plateau airway pressure. You set your ventilators so that you get these targeted values, and then you add a PEEP to this as a lung protective strategy, along with restrictive fluid strategy in these patients, plus an antibiotic coverage depending upon the antibiogram of your hospital. So the next thing to fail is your hypothalamus. So there is an alteration in the thyroid axis, there is an impaired temperature regulation and pituitary dysfunction. All this causes extreme hypothermia. So in extreme hypothermia, you have to ensure that you warm up the patient. So as I'd already said, there is central diabetes insipidus because of the failure of posterior pituitary function and depletion of ADH. Rule of thumb is, if the patient is pouring out urine for 500 ml in 2 hours, that is diagnostic of DI. And the goal is to maintain 1 to 3 ml. In case this happens, you have to run the protocol for diabetes insipidus as happens in the other intensive care units. There is nothing new in this. You can use desmopressin, alternatively vasopressin as continuous infusion, as we had already talked about. Be mindful of the sodium disruptions, so sodium values which may go beyond limits, and then monitor the blood glucose levels in these patients also. So for endocrine management, we are normally not recommending that you give hormonal therapy, but in patients who have got refractory shock, despite your max dose of your inotropes and vasopressors, if your patient is not pulling up the blood pressure, then it's good to give thyroxine. Typically, we have got only oral preps in India. So we are giving them through Ryle's tube, 200 mics OD. So this provides myocardial stability in patients who are extremely unstable, and the results are really good. So for hypothermia management, you have to warm up the lights, cover the patient with blankets. You can put hot packs, but be mindful, patient should not have burns. It should be properly wrapped in some cotton pads. Warm the fluids, warm the inspired gases. And if your patient doesn't have a temperature above 36, 35.5 or 36, patient cannot be subjected to apnea testing, because we all know in extreme hypothermia, patient can give M1 kind of a picture. So also know that patients can have coagulopathy because of the passage of necrotic brain tissue into the circulation and release of certain plasminogen activator. Now you will ask me, how is it going to affect me? So, well, we put all these patients on low dose molecular weight heparin because the microthrombi which form can also hamper the circulation to vital organs like kidney and lungs. So it's always good to have coagulation corrected. Also, coagulation is impacted by hypothermia and release of catecholamines and hemodilution as a result of fluid resuscitation and trauma. So the targets for electrolyte balances are very clear cut. You cannot have a patient subjected to apnea testing if sodium levels are beyond 155. So the work of the intensivist is to, give fluids. Fluids can go up to 4 to 6 liters also, the free fluids, to bring down the sodium values. And here we are not very concerned about the central myelinolysis because this is a brain dead patient. We are only trying to maintain the organs for subsequent donation. So calcium, magnesium, and phosphorus deficiencies are also common, and you can supplement them as you would do in any other patient. Along with this, we also recommend a trophic feed. We normally give a 250 kilocalories diet, and that's good enough to go because that prevents translocation of gut bacteria. Normally, corticosteroids are given when the patient has to go in for lung transplantation, methylprednisolone, and that reduces inflammation. And but routine use of hydrocorticosteroids, there is no high quality RCT suggesting its use. I normally give corticosteroids when my patient is having refractory shock and is not improving with vasopressor support. So along with this, you must remember to do general care of the patient. Patients' relatives are extremely sensitive to whatever you are doing. So please do not treat the patient as totally M1. You have to consider them as a potential donor. And you have to do hand hygiene, eye care, bronchial toileting, postural changes, care of catheters. And you have to do it very sincerely and expeditiously because prolonging the stay of the patient in ICU is also detrimental to the relatives who are sitting outside waiting to take away the body because they all know that patient is no more. And Dr. Jitendra has already highlighted, after all this is done, your patient is now fit to undergo apnea testing. So for apnea testing, we all know that these are the cutoffs in my center. Temperature 36, PaCO2 35 to 45, PaO2 more than 200, systolic blood pressure more than 100, or a MAP of more than 65, and sodium values less than 155. When all this is available to us, we approach the rotor team who brings in the apnea testing team, which is comprising of a big neurosurgeon, neurologist, ENT specialist, medicine, and intensivist, along with the hospital administration person. So it's a big team who comes, and these are some pictures from my own intensive care where apnea testing is happening in real life scenario. And if it is positive, then the patient, goes in for donation after the second testing is done. And it's been already told to you that the second testing is the time of death in these patients. And then there are some ancillary tests, which I'm not going to talk about because it's already talk to you regarding these tests. If your tests are indeterminate, what to do. But I would like to just add one more slide that there are certain confounders. Sometimes you would see that there are spontaneous movements of the limbs. They are due to spinal activity mostly. And what are these movements? There can be bilateral finger tremors. There can be repetitive leg movements. Patient can even show sometimes deep tendon reflexes, triple flexion response. Babinski's reflex is seen in 55% of the patients. A fair amount of patients show these things. And certain other clinical observations which are compatible with the diagnosis of brainstem death are facial myokymia, ocular microtremors, respiratory-like movements. Sometimes you will think that the patient, the ventilator is triggering, but actually it's not. Sometimes you may even see sweating, flushing, and tachycardia, and then suddenly the blood pressure, without pharmacological support, it becomes normal, or there is a sudden increase in blood pressure. So shoulder elevation, adduction, back arcing, intercostal expansion without significant tidal volumes. These are all, things to be very aware of. Don't think that the patient is, these are coming from the cortical cortex or from the brainstem reflexes. Sometimes these happens even with the spinal reflexes. And this is one case in our ICU where you can see the patient, when the patient was given deep painful stimulus, patient was flexing his arm. Actually, this patient was, these was only spinal activities, and these were not through the brainstem or the cortical activities. So these are sometimes confounders, and it creates a lot of confusion in intensive care, but it is always good to be very stringent, very careful that you are not missing out any signs of life. So the key points in the management of donation after brain death are that you must have checklists which improve the process of donation after brain death. You should have your own institutional maintenance strategies, which are fundamental to increase the number and quality of organs for transplantation. There should be a very good interaction between the intensive care team, operating room professionals, and transplant coordinators. It's very essential. And as the previous speaker also mentioned, that intensivist plays a key role in organ donation process, and we must be very sensitive to the fact that organ donation is the need of our country at this moment, and we must all work hard towards it and be very proactive in it. So this is the honor walk, which you must ensure once your patient is wheeled out of intensive care and into the operation theater. In my intensive care, it's a mandate that all residents, they will leave their work, stand in the corridor by the side of the warrior who is going into the operation theater to give life to others. So this is a very important step which you must never forget. And I request you all to be heroes by registering yourself as organ and tissue donor today, and be someone else's hero too. Thank you so much. And if there are any questions, I'm happy to take. Otherwise, you can follow me on X, and you can even mail me on my Gmail to ask for any protocols or any questions which come to your mind even after the webinar ends. So I'll stop my screen share.
Thank you so much, Dr. Kajal. There are a few questions. Actually, there are questions for 2-3 of you. We'll take them now. So one is, somebody said, how can artificial intelligence enhance the early identification, clinical assessment, and organ viability prediction in brain dead patients to improve the outcome in organ transplantation?
Well, we are yet to graduate to artificial intelligence because it is not yet been studied at all. Once we have some evidence from some studies, as such, are conducting RCTs and prospective trials is very difficult. It's a challenge to do in such scenarios because these are very sensitive matters. Most of the data is from retrospective studies, and to predict which patient will become and which patient will come through AI is a dream, I think. I don't think we are right now in that frame of mind. Maybe we'll have to wait for a few more years for the AI to, come of age to help us in this scenario.
There's another question for Dr. Sharma, I think, regarding apnea test. As mentioned, it isn't performed in the beginning. I wish to know how many of them are conducted.
Yeah. Before that, just a comment, which is a very interesting question. The AI help for the identification. So AI is a very umbrella term. There are so many facets for that. It can help in the scientific way, as well as it can help in a process improvement way. So as if now, Dr. Jain already mentioned, it is not the standard practice for the declaration of brain death and the care of the organ donation, but process can be little bit improved where the high volume center is there and the most of the CT scans are performed over there. The image related AI, which is which can be configured according to these are the finding in the brain scan. If find, they can alert the clinician to go about the thing early about the brain death identification as of now. Now coming to the original question, the apnea test. The question number one, why can't I perform early? See, till apnea test happens or second test happens, we call it as a possible brain death, not a brain death itself. Why? Suppose patient is not brain dead, in actually he is having a severe brain injury, and you perform the apnea test. This apnea test increases the carbon dioxide concentration in the brain, and it swells more this thing, and your test itself is a provocative test. Previously, probably patient wasn't qualifying the brain death, and your test actually make this patient brain death. That's why until unless your initial part is very clear, if you are, so that's why if there is a confusion in the comma, then still your a complete brain stem reflexes may or may not be. It would be your part of clinical examination. Anyway, you can go for the clinical examination. So from the step 1, step 2 doesn't make any difference whether your intention is to declare the brain death and you are doing the pupillary reflex or cold caloric test, or even you're not intention. It hardly makes any difference because it's a part of a clinical examination. But apnea test, until unless rest of things are in your favor, then only it can be. It must be done after that. That's why, because it is a provocative test in nature. And second part was how it has to be repeat twice. There are certain nuances I didn't cover it. Say, for example, 6 hours for adult is some time or more. One set of the committee, theoretically, one set of the committee perform the one test, and the till 6 hours, suppose some problem happens, all the committee member are not available. Then what should be done? The next committee and all these are certain nuances over there where the law says at least one person must be common in both the committee who personally witness the apnea test. So that's because theoretically possible. You have 4 members. Suppose some emergency happens and they goes out, and the next 6 hours they may not really become a part of this committee. But at least one member has to be there who witnessed the apnea test. That was the answer. One more question I found in the chat box is, if brain functions are absent, then how does the heart keeps functioning? That was a question over there. So heart even can beat outside the body. So heart is having a autonomicity over there. So heart can beat outside the body. That's why that's the which you can say a opportunity, and that's what we avail this opportunity for the organ donation, the brain death, which is the ideal one because the perfusion is still maintained. The cardiac death donor is relatively more enthusiastic kind of a program where after immediate cardiac arrest, you have to retrieve the organ. Immediately the ischemia time and all these things is not in the favor of the donated organ, but the brain stem and especially once declared and it taken care by the intensivist for the donor care is extremely difficult. It is equal to 1 or 2 critical ill patient caring the just for, because usually you care the one patient. Here each and every organ you have to maintain this, and the precise answer for that, yes, cardiac activity, and the over and above, it can't be a longer period. You can't keep the brain death patients on and on for days, 2 weeks. There's a difference between vegetative and the brain death. So this nature gives us an opportunity. It varies according to the patient to patient. Few patients sustain few hours to maybe a couple of days after the brain death. Eventually your cardiac death will happen because of the release of the vasomotor centers and all cytokines, and eventually the cardiac death happen. And this window period usually lasts few hours to maybe a 24 hour, 48 hours. And that's where you perform all your scientific as well as the legal processes for the organ donation and retrieval.
Thank you. Any more questions for Dr. Kajal and Dr. Sharma? If you have any, I suggest you ask them now. They are, they have taken their time out. So if you need, if anybody wants to ask, you can also unmute and ask. No, I think they've all been asked.
So last, because all are are young budding doctors. One important thing, the ancillary test which you see is the impaired function. So brain is a very unique organ in the body. When it stops functioning, it doesn't take the perfusion. And that is the basis for your ancillary test. That is the unique. Even if your muscle is not working, it will not stop. The circulation would be over there. Even the heart, it would be over there. even the MI happens, but the coronary perfusion would be there. Either it is, if it is cause for the obstruction, then it's okay. But whatever reason, even your circulatory brain circulation is absolutely fine, and injury happens over the widespread cortical region. Once the brain stop functioning, there won't be perfusion, and that is the mainstay for our ancillary test where we can go for the perfusions.
Okay. Thank you so much, Dr. Sharma and Dr. Kajal. Thank you so much for taking your time out and being here. There is one question for Dr. Ashish Sharma, if he's still here, which was asked earlier. Dr. Sharma, are you here?
So I don't think so. Maybe they can post the question to him and we can answer it.
Right.
Yeah, please. Yeah, I can listen actually.
Acha, he's here. Okay. So the question is, what is the nearest authority to which a family of the dead can approach for organ donation? And the second one is, are all medical colleges NTORCs?
So, I mean, currently you have to get approval for getting permission to have an organ donation license in place. So all medical colleges cannot be currently. You cannot have organ donation happening at all medical college unless you have that requisite license and permission. So that is one part. And the second question was, sorry, I missed that.
What is the nearest authority to which the family of the dead can approach for organ donation? And I'm not sure.
Basically, yeah, so I mean, it's not a straightforward thing. So most organ donations would only happen if you die in an hospital, right? So there, during that process, you will be approached by the transplant coordinator. So as such, I mean, you will not go and say that, okay, from your home that I want to donate. If you are in a place where the hospital is not licensed for donation, and then you come to know of your brain death of your near and dear one, so then you can approach the state organ and tissue transplant organization. So they will have either the SOTO or the ROTO or the NOTO. So any of these, so they can then coordinate. Either they can give a temporary permission for that hospital to be designated as a retrieval center for that particular patient, or they can guide you that you can shift your family person to a nearby hospital, which is a recognized organ retrieval center. But I think, I mean, we've been asking repeatedly that you probably should allow at least all medical colleges to become organ retrieval centers. So that, but again, till the time the law is modified, it actually cannot happen.
All right. Thank you so much. So we'll move out. We can continue to leave your questions in the chat box. We'll move on to our last talk, and I'd like to invite Dr. Navdeep Bansal, who is the transplant coordinator at PGIM-ER Chandigarh. He is a two-time awardee of the Best Transplant Coordinator at the national level by NOTO, which is a National Organ and Tissue Transplant Organization, in 2017 and 2020. He has written for various national and international journals and is the author of a handbook for transplant coordinators. He has successfully coordinated more than 180 cadaver organ donations. His topic today is providing compassionate grief counseling to donor families and approaching the family for organ donation. Welcome, Dr. Navdeep.
Good evening, everyone. Thanks to the Organ India for giving me the opportunity to share my experience in this field. So now we are going to discuss that how we can approach a family, like everything is discussed, that how the patient is declared brain dead. Hello, am I audible?
Yes, you're
Yes,
audible.
Dr. Bansal, yeah.
Okay. So everything is discussed, that how to declare a patient brain dead and how to care a potential brain dead patient in the ICU. So now we will discuss that how to convert that potential donor to the actual donor, but the various ways that how we can approach the family regarding organ donation. So in this talk, we will discuss that how we will approach the family and how to proceed if you feel that in any ICU or in any setup where there is any potential brain dead patient, how to proceed for that patient to convert him in an actual brain dead donor. So how it started when the family is still in shock that they are going to lose their loved one. We have to break the news of being a brain dead, and it may take a number of sessions to motivate the family regarding organ donation. And if the family say yes, the many lives can be saved. So how it started? Whenever you feel that in your ICU setup you are having any patient with GCS3 or any M1 patient, you feel that it can be a potentially brain dead patient. So a request is given by the treating doctor along with the transplant coordinator to the in charge of the hospital or the medical superintendent of that hospital to constitute a brain dead declaration committee to declare that patient brain dead. That committee members are the 4 members that are discussed in the previous talks. So that committee is constituted to declare that patient brain dead. And after that, they will conduct the various tests and discussed by Dr. Jitendra that they will perform the ancillary test or the various tests like the apnea and the brainstem reflexes they will check. And they will use this form 10, to declare that patient brain dead in both the committees. So if the patient is declared brain dead, and that explaining that the situation to the family is one of the difficult situation for the healthcare professionals, but how we are going to communicate will overall decide the final decision of the family regarding organ donation. So when you have to break this news to the family regarding brain death, you have to keep in mind that when you are going to break this, to whom you are going to break this, and how you are going to break this news to the family. So when it should be after the first brain declaration, then when the first patient is declared brain dead during the first brain dead declaration committee, and whom it should be to the next of the kin available in the hospital or the person who is going to affect the decision of the family, and by whom it should be the brain death declaration should be explained by the treating doctor or the ICU team, but regarding organ donation, it should be approached by the transplant coordinator. So these are the few strategies which can be used when we are going to approach the family regarding brain death or the organ donation. These may vary from family to family or related to their level of understanding or their level of education and their acceptance of the death of their family member. But these are the few strategies which can be used when we are going to approach that family. First is preparation, that you should be fully prepared when you are going to approach the family, and that news should be broken in a comfortable and a conducive environment where the family can accept this news and can express themselves. And it should be done at a suitable time when you are and the family is free to listen your communication with the family, and it should be explained clearly to the family. So we will discuss one by one. So prepare in advance. When you are going to approach the family, collect as much as information from the secondary sources of data as you can. Like you should be aware what's the reason of brain death, when the patient came in your setup or the hospital, what were the various procedures, whether there was any operation was done or not, or what was the treatment provided to the family, so that when you are going to approach the family should feel that okay, you are fully aware about their patient and its care. And also determine what information the family already know. Always approach to the treating staff who is taking care of the patient from the last few days, that how the family is coping with the poor prognosis of the patient, whether they are going for any religious rituals. And most important is also ask about the support person from the treating staff, that who is taking care of the patient, who is asking again and again, asking about the prognosis of the patient, or getting involved in the treatment of the patient, so that you can when you are going to approach that family, you can target that person, that that person will influence the overall decision of the family regarding the brain death or the organ donation. So when you are going to break this news, always break this news in a private room where the family can fully express. The family can express themselves, and it should be done in a comfortable, ideal environment for where the door it should be closed and sufficient sitting for all the members should be there. Like in our setup, we are having a separate room for the transplant coordinators where we do the grief counseling and the counseling regarding organ donation. It's in the trauma center only, near to the our trauma OPD or the emergency, and near to the trauma ICU. Allow sufficient time when you are choosing the time that when you are going to discuss regarding the brain death. Select a time because it can family is going to lose their loved one, so the understanding of that brain death can take more than 1 hour, or it can be done in the 2-3 sessions also. So select a time when you are free from any other duty, and also the whole the family or the decision makers are there to whom you are going to discuss regarding the brain death. So always clearly explain the concept of brain death, that what's the brain death, how it's different from the natural death, and on which basis we are declaring the patient dead. Provide information as much as they want, as the family can be sensitive to their understanding, as the family is going to lose their family member, so they may not be able to understand few of the things. So you have to be patient and you have to be sensitive to regarding their patient. You need to explain everything again and again to the family. So be sensitive to their feelings and provide as much as information the family wants. Even after your discussion, if your session is over, then be available and approachable for the family. Explain them or give your contact details to the family, or tell them where you will be available if they want to discuss further regarding brain death. So now when you have explained regarding the brain death, then you have to approach the family regarding organ donation. So while you are going to approach the family regarding organ donation, you have to keep in mind the various stages of grief in mind. So first will be the denial phase. When you are going to explain the brain death to the family will deny. Deny regarding the brain death. It cannot happen to their family member, or and they will fully deny the situation of death of their family member. And after that, they will show anger. This anger can be on the hospital services, or their delay in bringing the patient to the hospital, or on the God. So you have to accept this feeling, the anger of the family, and also after that they will bargain from you. Please save our patient by any means. We are ready to pay. We are ready to shift the patient, or we can do anything to save our family members. So they will bargain from the God and from the you that please save our patient by any means we can do. And then after that there will be a phase of depression, where there will be the no communication with the family members. And after that there will be some acceptance, although this acceptance is not the final stage of grief of the family, but at that particular situation, at that particular time, and that hospital setting, there will be some acceptance within the family. Okay, we are explaining the brain death, or they will accept that okay, now their loved one is not going to survive and they are going to lose him or her. So that's the best time then that when you have to approach the family regarding brain death. So when you have to approach the family regarding organ donation, and there should a family consent for organ donation should never be started unless there is clear understanding by the family regarding brain death. Until the family is not able to accept the brain death of their family member, never approach the family regarding organ donation. And always keep in mind the various stages of grief, like explained now, that we have to approach the family when the family is able to accept the brain death of their family member. Let family speak first if they wish. So this is the best time you have to approach the family regarding organ donation, that now the family accepted that okay, their loved one is not going to survive, and they will ask you, okay, then when we will get the body, or what's next, what's the next process, and how much time they will have to stay in the hospital, So that's the time that when you can explain them that okay, your loved one is no more. What are the options now? And regarding organ donation, you can explain everything that how that family member is going to change the life of others. So when the family will speak or the accept the brain death of their family member, that's the time we have to introduce the topic of organ donation with the family. Try to comfort them by showing empathy, care, and positive approach. Always show a positive approach, whether the family is going to accept regarding the organ donation or not. So always show a positive praise to the family. Choose the key person. That's very important. You feel that which person is going to affect the overall decision of the family. Always choose that person. He or should be there when you are going to start the discussion regarding organ donation. Boost the donor image. Always boost the donor image, that how their family member is going to change the life of others. Provide complete information about organ donation, that how much time it will take, what type of incision will be given, when the patient will be shifted to the OT, what organs can be utilized, and how much time it will take for the overall process, and about the incision and so. And if possible, always use the previous cuttings we use in our setting, that we use the previous examples, we show them the pictures about the various age groups and how the previous donors have changed the life of others. So you can use the previous paper cuttings or the articles or the news clippings. Approaching the family, when what type of communication you should use, always ask the open-ended question. Okay, if the family is interested about the organ donation, or if they are going to give the consent, always ask. But they always ask what you have understood regarding the organ donation, so that you should be clear that okay, the family is not so in so much grief that they don't know but which documents they are going to sign. So always ask the open-ended question. The family should explain that what they are going to do regarding organ donation, if they are going to give a consent or not. So always use the open-ended question. Never make any false promises which you feel you cannot fulfill after the donation. Never commit the particular time when you will hand over the body, or any give and take regarding the organ donation, or the identity of the recipient. So never make any false promises which you cannot fulfill during the process of organ donation. Give family enough time to consider if the donor is stable. There is no hurry. Give the family enough time to consider the concept of organ donation, because it's a difficult decision for the family to lose their family member. Once family understand the whole concept of donation, request for consent of organ donation after the second brain death declaration committee, and the written consent should be taken after the second brain death declaration committee, and you have to complete all the documentation related to the organ donation. If the family is ready to give consent, keep them constantly informed. If the family give consent, then you have to keep them constantly informed that what's going on, when they can meet the donor last time, or when if they want to do any last ritual. So you have to keep them constantly informed that that when you are going to shift the patient to the OT. Your communication skills should be appropriate when you are approaching the family. Your both verbal and the non-verbal communication should convey the same things. Always use a simple language that the family can understand. Always become active listener when you are discussing regarding the organ donation or the brain death with the family. So that family should feel that you are totally aware what the discussion is going on, and avoid the use of mobile phones or at that time. Avoid too many medical terms like kept on life support. Avoid such terms like the patient is kept live for the organ donation only, or the patient is kept on the life support. Always convey that brain death means death. So that concept should be clearly explained to the family. And at the same time, your non-verbal communication, your eye contact, your sitting posture, and the body language, you should be empathetic with the family when you are going to discuss the concept of organ donation with the family. And if the family is agreed, then you have to use this form 8 if the family is going to give the consent, where the next of the kin will sign this form if they are willing for organ donation, and also there will be the two witness who will witness the consent of the next of the family for organ donation. And and these are the donor maintenance kits that are used in our setup. When the family give consent, all the charges after that are waived off for the family. So if we are going to keep the after consent, if the donor has to stay in the ICU for the next 24 hours or 48 hours, then we provide these kits to our ICU team, so that so that they can keep the donor in the ICU for next 24 hours or 48 hours as required. So at the same time, you have to take a forensic NOC. If it's a MLC case, then you have to take a NOC from the forensic team that whether the organs can be retrieved before postmortem or not. So you have to take a forensic NOC from the family, and also a intimation of the NOC is to be taken from the investigating officer of that case in case of MLC cases. So what are the various common issues which the family will discuss during your counseling or your communication with the family? The most of them, the most challenging thing is to accept the brain death. Family will say how you can say that our family member is no more. Still the pulse is going on, the BP is there, the patient is passing urine, and so on. There can be some flickering movements of the spinal flexors also. So the family will not accept the concept of brain death. So that's the main challenge, I think, that we are not able to increase the organ donation. So accepting this death is very difficult. So you have to explain them clearly that what you mean by brain death and how it's different from the natural death. Go for recovery, that always will be there. The family sometimes will say that they have listened that even the patient can come back even during the postmortem and so always there will be hope of recovery for the family, but you have to explain that it's a brain death, it's different from vegetative state or the coma. You have to explain them that the patient cannot survive without the ventilator support. So cultural and religious beliefs will be there. Few of the communities are not in favor of the organ donation. So, but we have to explain them that it's the best donation or it's the life they can give to someone. So you have to explain them regarding the this organ donation and how it's supported by the various religious organizations. And also the main concern of the family will be the disfigurement of the body. Most of the families will feel that if they are going to donate the organs of their family members, then they will not be able to do the last rituals of their family members. But we can easily justify this thing if it's a MLC case, and as in the most of the MLC cases, the postmortem will be there. So the incision will be same that will be used in postmortem for the postmortem. So we have to justify that in case of MLC cases, and in case of non-MLC cases, we can explain them that this retrieval of organs will just same be the normal surgery for the patient. That the same type of suturing will be used, and the family can do their last rituals without any issues. And that's also a challenge that the family members say that okay, we are ready, we have no objection, but my relatives or my community influence is there that I cannot go for the organ donation. And also some negative news related to the sale of the organs and so in the community also affect their decision regarding the organ donation. So we have to clarify this also during our conversation with the family. And it's a time consuming process. Sometimes when you will explain to the family that okay, your patient is no more and you are ready with the death certificate of the patient, and so the family will be in hurry. They will not stay in the hospital for the organ donation. They at that time they will say we are not ready to help anyone else if our patient is no more. So you have to make them understand that it's a time consuming process. It's a legal and medical process, so it may take time. So when you are approaching the family regarding organ donation, you have to keep in this mind that they have to stay in the hospital for the next 24 hours or so for the whole process of organ retrieval and donation. So also the family will ask, okay, we are ready to give the consent, but we want to know where the organs will be utilized. That also a issue, because as per the TOTA Act, we cannot reveal the identity of the recipients with the donor families. So you have to make them understand that that is not possible as per the act. But if you feel that you are losing the organs due to this concept only, you can use some control measures to reveal, not to reveal the identity, but you can use some control measure to just have a look of the recipient to the donor family if they insist. So these are the things you have to keep in mind while approaching the family. And even if with all your efforts, the family is not ready to give the consent, or they are not ready for the organ donation, you have to accept that refusal gracefully, because their no can change into a yes at any time. So accept their refusal gracefully, and if they give consent, and this is the stamp or the donor preference stamp we use in our setting. If the family gave consent, then we apply this stamp to all the documents or all the investigations we required on the investigations of the donor. We apply this stamp, and everyone is aware that if this stamp is there, then there is no required to submit any fees for that test or the investigation, and also the priority will be given. They will use that sample as the priority to generate the report. So in the end, with your efforts, it can be the beginning of someone on a transplant list. Thank you.
Thank you, Dr. Navdeep. Are there any questions for Dr. Bansal? Dr. Bansal, actually, I have a question.
Yes, ma'am.
Any particular one case which you which you remember where the doctors played a crucial role in sensitizing the family, as well as maybe making them change their mind about organ donation?
Yes, ma'am. I think in almost every case, the ICU team plays a crucial role. The team led by Kajal ma'am is playing a crucial role in making the. Actually, we follow that the brain death or the poor prognosis is always explained by the treating team or the doctors of in the ICU, and the approach regarding organ donation is always done by the transplant team. So if they are able to make the family understand that their family member is no more, or he or she is brain dead, though, then they make it easy for us to counsel them regarding organ donation. So the ICU team always play an important role in the organ donation.
Okay. Thank you. Any questions for Dr. Navdeep? You can please unmute yourself and ask.
No, may I go ahead?
Yeah, please go ahead.
Sir, I just had a question. Like, recently my family experienced a death of a family member, and when I proposed that we can opt for organ donation, everyone was like, as you mentioned, they have their different stages of grief. Everyone was in a different stage, but what can, as a medical student, like at the end of the day, we are a medical student, at the same time, we might just be the youngest in the family. So what can we say, or how, any particular phrases or something that we can use so that our families encourage for organ donation in times like that?
Yes, you can convince the family member, like I discussed, that you can show them the previous donor pictures of the previous donors, or you can explain that how even after death, how that family member is going to live, like his or her eyes are going to see this world even after death, and even their heart is going to beat after death. So you can explain such type of things, that okay, we are going to cremate the body or bury the body, or then there is nothing that will left with the family. So you can explain that how by donating the organs, how you can keep that person alive. So such type of things you can discuss with the family and convince them for organ donation.
Thank you, sir.
Okay, any more questions? Otherwise, we can close the session.
Ma'am, we would like to take a picture.
So Naina ma'am, I'll take over and then maybe we'll take a picture.
Yes, sure.
Yeah.
Dr. Mansal, can you stop the sharing, please?
Sure.
This is an announcement for everyone. The post-evaluation form has been shared in the chat box. Please fill it up as it will not be shared again in the group. And I would also like to take this opportunity to thank Organ India, Sunaina ma'am and Saurabh sir was present with us, and also the speakers, Dr. Ashish, Dr. Ravi, Dr. Jitendra, Dr. Kajal, and Dr. Navdeep, who were present with us today, and on behalf of MSCI, Medical Student Association of India, and all the participants, we want to extend our heartfelt gratitude to taking the schedule and share your expertise during the webinar. And each session got a very invaluable insight, be it ranging from landscape of organ donation to how management is done in ICU, and also about sensitive art of counseling the patient party. So your input not only help us understand but also inspire us as future professionals to approach this field with greater responsibility and empathy. So thank you so much for contributing and having an impactful and enlightening event with us. We look forward to future opportunities for learning and collaboration. Thank you, Organ India and all our speakers.
Thank you. So shall we take a photograph?
Yes, we can take the photograph. Everyone can put your cameras on. Whoever want to put your cameras on, you all can.
Dr. Bansal, I think you're still sharing your screen. Somebody is sharing the screen. And yeah, okay.
Drashti or Ovia, if any of you are on your laptop, can you all take the picture? Okay, Drashti, you're taking the picture. Okay, do a countdown. We'll just wait for some time for everyone to put their cameras on, then we can take a picture.
No. Okay, we'll wait for 5 more seconds. Okay. And 5, 4, everyone keep smiling. 3, 2, 1. Okay, we are still turning on our cameras. Okay, say cheese. Okay, just last picture. Perfect. Thank you so much, guys, for attending. We have added the post event in the form, in the group chat here, and at the same time in the live of what YouTube. Additionally, at the end of the form, we have attached organ donation registration form. So we would really emphasize on you guys registering as an organ donor. Over to you, Partho.
Yeah, I think that is it. And we'll also share the organ donor registration form in the group also. So please, all those who want to register yourself or anybody, you all can take that form and register yourself. And if Sunaina ma'am want to add anything regarding the organ donation registration form, or you can add that, ma'am.
Yeah, I mean, it's not mandatory that you register, obviously, as you heard that it's the family who takes the final decision. So please, speak to your family. More than registering for it, you should speak to your family. Just, have a chat with them. They don't like, nobody likes to talk about death, but it's all right. It's going to come for all of us. And you can just start the conversation now, talk about eye donation, if not organ donation, and then slowly progress to organ donation so that, the family is used to it. And that's it. Yeah, please follow our page. It's organ_India. We keep posting. And in fact, we are now taking India's transplant team, which is basically a team made up of transplant recipients of all heart, liver, kidney, lungs, whatever, to the World Transplant Games. So just like Paralympics, there are World Transplant Games. And we are the team managers for the team, and we are going to Germany to participate in the World Transplant Games. So please do follow our page. It's organ_India. Keep abreast of what's happening. If you'd like to do any particular kind of, a webinar which is only focused towards certain things, you please let your VP know, let Dr. Partho know, and we can arrange that as well. And yeah, just keep thinking about organ donation. You are the first line of, you are going to be the ones who are going to, in every capacity, be there to start the organ donation process. So you should definitely, all of you should know more, as much as you can, about organ donation. And thank you all the doctors who have come all the way, Dr. Sharma, Dr. Bansal, Dr. Mohanka, and Dr. Jain. I think they're no longer here, but thank you so much for being here. And thank you all of you for taking so much time out of your Sunday, for this. Okay, that's it for me. Thank you.
Thank you. Thank you so much, ma'am. Leah,
Yeah,
could you stop the live?
yeah.